move here. No?
Sir, this is forward, this is backward.
No, no, no. Some
Oh.
cursor here.
Okay, cursor is there.
I am, friends, I am so thankful to the organizers, Shiv Kumar, Srinivas, Professor Pahlajani, and I was lucky to be in the room when Professor Satyavan Sharma was speaking. Yes, it's wonderful to listen to you again, sir. So, in fact, you have been our teachers. We have learned from you in various forums, be it a lecture or Professor Satyavan Sharma would remember that he had come to our place when we had started our mitral program. So there are so many memories, and speaking in front of my teachers makes me a bit nervous. But I hope I'll pass in front of you. So let us go to how to approach a case of left to right shunt. Now, how can I have a cursor here? Yes. Now, in acyanotic congenital heart disease, left-right shunts are obstructive lesions, and my job has been to discuss the approach to this. But before I go there, this is a simple thing. It's a commonest congenital heart disease. It is easily diagnosable, treatable with good outcome. But all these left to right heart shunts do not require treatment. Unfortunately, if you leave some, they may have a complication which you later cannot correct. So before going, I would go to fetal circulation, one of the aspects which have been removed from the textbooks now. But often I have seen that students are hesitating when they are trying to talk about why this happens in shunts and why this does not happen. I would come back to certain points and I remind you that umbilical vein is a single vein which brings the vein blood from placenta, oxygenated blood, goes through the liver, but doesn't mix, passes the hepatocytes and goes into the right heart, and then selectively goes with the IVC blood, it mixes, but total mixing is not there. And selectively, the eustachian valve is directed towards the left heart. From right heart, right atrium, it goes selectively to the left atrium. So left atrium is receiving a more saturated blood. Then SVC blood and IVC blood, they preferentially flow to the right ventricle, and then they go to the pulmonary artery. Now from pulmonary artery, since the lungs are fluid filled, remember this? Fluid filled, we'll come to that later, and are collapsed. So there is a very high pulmonary vascular resistance. So what happens? Blood goes from right ventricle into the pulmonary artery, comes back, and then goes through the patent ductus into the lower limb. So RV output therefore goes to the lower part of the body, and the upper part, that is brain, is circulated by the left atrium, higher saturated blood, and coming from the left ventricle. So few things are clear, that it is a parallel circulation. Not truly parallel, but if you remember, or if you see here, the upper limb is being circulated, head and neck is being by the other way, and the lower right ventricle is pumping into the umbilical artery, which goes for the gas exchange, comes back with umbilical vein, goes again to the umbilical artery. So these are two parallel circulations, and there is a large amount of right to left shunting. Where is it happening? At the level of pulmonary artery, from where the blood is going through the ductus arteriosus into the descending aorta. And placenta is the oxygenation site. So let us see what is the oxygenation levels at that level. So when the umbilical vein, that is when it is carrying the blood, carries 80%. So that is the highest saturation compared to 95 or 100% in the pulmonary vein. Here it is 86%, 80%. Inferior vena cava, superior vena cava, they both carry 25%. Right atrium, 50%. But left atrium, because of selective shunting of blood of the ductus venosus through the eustachian valve, is having 60%. So ascending aorta, brain receives 60%. Pulmonary arteries, descending aorta, umbilical arteries, they're all having 45%. So you must be wondering what happens, how are they saturated? Because the extraction, it is only 80% saturated. What is happening, how the child is growing or how the fetus is growing? It is because of fetal hemoglobin. The fetal hemoglobin is very, very closely attaching. It has a capability of attaching to oxygen more than what the adult hemoglobin has. There it comes into play. So saturations, despite lower saturations, the development is good enough. Now, few things again I would say. Here, since they are parallel circulation, the cardiac output will not be determined of one chamber. In fact, right ventricle and left ventricle both have different cardiac outputs. And you see here, the right ventricular output is 60 to 65% of the total cardiac output. That makes it a dominant ventricle. It is more dominant, more stronger ventricle. Second thing is important is that 45% of the total output is going into the umbilical artery for oxygenation. Upper part of the body receives 25%, lower part receives 25%. So they are surviving only on this, and the major portion is going for the oxygenation. That is second aspect. And third and more important, pulmonary artery pressure is same as the aorta pressure. Why? Because of the large ductus, which is same size as vein pulmonary artery or the aorta. So pressures are both same. See here, the pulmonary artery pressure is 50 to 60 millimeters, destined to fall to 20 or 25 in a normal newborn. And aorta is destined to go up 20 millimeter higher, from 60 to 80. Remember these things. And LA and RA pressures are same, 5 to 6 millimeters. So now let us go, what happens when? And see what is happening at isthmus. You remembered that from aorta, the blood has gone to the upper limb, and from the pulmonary artery, the blood has gone through the descending aorta by the ductus arteriosus. So there is no supply at the isthmus. Isthmus receives minimum, so only 10% of the cardiac output goes through the isthmus. That is the reason why coarctation develops here. It is at the isthmus because it is not having enough expansile pressure, and these are further implications which you will read later. Now what is happening at the birth? With the inspiration, there is marked reduction in pulmonary vascular resistance. So that is one critical thing that has to happen. The child has to take a breath. The air has to enter. And at the same time, once the PVR goes down, the pulmonary blood flow increases, leading to increased left atrial volume. Why? Because the pulmonary blood is now getting saturated. Functionally, it closes the foramen ovale because the left atrial pressure has gone higher. At the same time, once you have clamped the umbilical vein and arteries, the venous return to right atrium has gone down. So right atrium gets lower, left atrium gets higher, the hinge mechanism closes the foramen ovale. And ductus arteriosus closes functionally also. Why? Because ductus, to keep the ductus open, the blood through that has to be hypoxic. Once the hypoxic blood is not there, hypoxic blood is further stimulus for release of other substances, which this information you use later in preterm infants. So this is what happens, and establishment of a circulation, series circulation starts, right? So these are the quick things. You lose placenta, you get the increase in SVR, lung expand mechanically, oxygen as vasodilatation causes pulmonary vascular bed to dilate, PVR goes down, and remember, it is not only that there are certain more things happen here, is that the acinar arteries continue to grow if the stimulus or if the pulmonary artery pressure goes down, even after birth. And then the total cross-sectional area of acinar arteries goes on increasing, maximal in the first year and later till 8 or 10 years. That means the cross-sectional area for the gas exchange as well is more. That means if it is a normal child, the vasculature goes on having reduction of PVR even substantially after birth, up to 1 year, 2 year, 3 year, because the augmentation of other acinar vessels. And that will also be important. So what are the changes happening? And this is a beautiful, I am not sure whether you're able to see that. There's seminal work from Rudolph done in 70s. There's a beautiful article, and Rudolph has been most influential. I don't think that we have been able to improve. Remember this figure. It is showing the pulmonary vasculature resistance, pulmonary blood flow, pulmonary arterial pressure, and muscle thickness. And this is the time when there is a birth. And here, this is their course over 1, 2, 3, 4, 5 weeks. Now, PVR, first one, markedly falls at birth. See here, it has fallen here, but continues to fall for 1 more week, and continues to fall even further for 4 to 5 weeks. Why is this happening? Because the fluid that was there in the collapsed bronchus or the airway is not immediately absorbed. It takes about a week's time. That is why as the fluid gets absorbed, the gaseous exchange is more, the alveoli are augmented, and PVR keeps on going down even at 1 week. So by the end of 1 week, the adult SVR PVR ratio is maintained, not at birth, but at the end of 1 month. The ratio, but see here, the PVR is still falling. Similarly, the PA pressure falls. This is the PA pressure. See here, it was 60 or 75, and it has fallen down here to 25 at 1 week. Immediately at birth, if because of some reason ductus is open or there is some stimulus to maintain the pressure, we'll come to that, the pulmonary artery pressure will not fall. That you must remember. The pulmonary artery muscle thickness reduces by the end of 4 to 6 weeks. This is the pulmonary artery muscle thickness. Now, because of some stimuli which will retain the pulmonary arterial pressure, they will also not let pulmonary arteries lose media. That is known as involution. When the pulmonary artery loses its media, it becomes more capacitous, and that further makes them capable of reducing PVR and accommodating more blood. Interesting thing here is that the pulmonary artery muscle thickness reduces totally by 4 to 6 weeks. But remember, the right ventricle was more dominant hypertrophied ventricle that also has to shed muscle. That takes time. That takes about 6 to 8 months time. And that will come in play when there is a pre-tricuspid shunt. In post-tricuspid shunts, the pulmonary artery is exposed to high pressure of left ventricle. They don't get time, pulmonary arteries don't get time for involution. But what is happening in atrial septal defect? The right ventricle is the determinant chamber of how much blood is going from left to right. Left atrium to right atrium, and in diastole, right ventricle will decide how much blood is going to come in the right circulation. In the meantime, pulmonary artery involutes. When the right ventricle involutes at the end of 6 to 8 months, now the shunt will be established. That is why the shunt establishment in atrial septal defect or pre-tricuspid shunt is much later, and the children or newborn are never symptomatic. Remember this. Now, what are the factors which are against this? These are preterm, hypoxia because of any reason, respiratory infection or whatever, lung pathology, and fourth is pulmonary blood flow if it is increased because of presence of shunts. So what will happen there? The PVR will not fall. That is one thing will happen because of any stimulus. The pulmonary blood flow will not increase. It will remain reduced because PVR will not fall. The pulmonary arterial pressure will remain higher, and then the muscle thickness will not go down because there is a constant stimulus for it to remain hypertrophied. So that is what happens in the presence of large left to right shunt, particularly at the ventricular level, but not when it is in the pre-tricuspid area. I hope this clears the physiology why it happens. So at the time of birth, sudden things happen which are favorable. PVR falls, blood flow improves, the pulmonary arterial pressure comes down from 60 to 25, and the media, arteries lose media. But because of these factors, if there are any, this will not happen. That is why the Paul Wood has written that in VSD with Eisenmenger, cyanosis dates back to infancy. If I ask you, when will the child of VSD have cyanosis? You will not say at birth or in infancy. You will say he will get it somewhere in the second decade. But what Paul Wood had written is that if because of any reason, if the child has pneumonitis or anoxia, there will be no fall in the pulmonary arterial pressure at birth, even in VSD, and so there will be a history of cyanosis. That is what he meant when he wrote that history dates back to infancy. History of cyanosis dates back to infancy. So this is what we have talked about. In post-tricuspid large defect, pulmonary artery are exposed to increased systolic pressure of LV from the very beginning. A large defect will delay PVR fall. Large shunt will be established when PVR falls. And when it is falling, the lowest level comes by 3 to 4 weeks. But did you see, if it is a normal fall, if the flow is increased, it will fall further, it will be delayed further. So you will be having establishment of shunt even after 1 month or 1.5 months. In pre-tricuspid shunt, the PVR falls normally, but shunt is not established because the RV has not involuted. Large shunts in pre-tricuspid are established at 6 months to 1 year of age. You will never hear a history, or you will never get a history of, let us say, failure to thrive in atrial septal defect. No. And this is the same thing in pre-tricuspid and ASD for large defect pre-tricuspid, telling us the same thing about. Now, why are we bothered about left to right shunt? Is heart failure is here with normal LV function, which may kill. This is very unusual. And second is pulmonary arterial hypertension. Why is there a heart failure? Because lung is fluid filled. The fluid has not been expelled yet. The capacitance of lung is reduced, and tachypnea or work of breathing is increased. There is increased venous return of the left side because of increased left to right shunt. Left ventricular end diastolic pressure is increased, and something like a pulmonary edema happens. This gives stimulus to left ventricular dilatation because the infant's heart is not good enough to take the volume. That is why it fails. For the same given similar volume or even a larger volume, the atrial septal defect does not produce heart failure. Why is it so? Because by the end of 1 year or 1.5 years, when the presentation starts, the heart is able to handle that much amount of blood flow. But in an neonate or infant, those stimuli are not there. The myocardium, as well as the autonomic mechanisms, they fail, they overreact. Autonomic systems overreact and they fail. Similarly, the heart is not able to cope up with that volume and fails, and tachycardia. What happens with increased prolonged left to right shunt? There is persistent exposure of pulmonary vasculature to high pressure and flow. There are structural changes in pulmonary vasculature, medial hypertrophy and intimal proliferation. Till this stage, it is reversible. But if it is going beyond that stage, then there are fibrosis and obliteration of the arterioles and capillaries, which is then labeled as irreversible, and then the patient enters into Eisenmenger syndrome. Hence, early recognition of those patients is important because you can intervene earlier. Now, pulmonary arterial hypertension in congenital heart disease, there are certain figures which somebody may ask you. In atrial septal defect, it is 10 to 15%. I'll be only talking about other things you will get in the text. What is the age of development? That I'll not go into. In ventricular septal defect, 50% of them will have. In AV canal defects, nearly 75–80%, and all AP windows will have this. Remember this. Has our understanding about pulmonary veno-occlusive disease has changed? And this is what I was talking about. Recent articles have confirmed what the earlier studies were, that in patients who are having Eisenmenger, the cross-sectional vascular area is lesser, rather than only obliterative changes. It is the total vascular area which is also lesser. Why? Because the acinar vessels have not grown in the early infancy and early childhood, so the pulmonary vascular resistance has not been lower. So some people say they are destined to go into pulmonary hypertension. Now, what is the determinant of shunt size? These are the two determinants of left to right shunt. One is the defect size itself, and second is pulmonary vascular resistance. High PVR will resist the large shunt. Now, these are this you all know, I believe. There may be small shunt, moderate shunt, or large shunt. To make it simple, let us say that small shunt is 1.5:1, large shunt is 2:1. In between, you can have moderate shunt. Is there a correlation between defect size and shunt size? Not exactly, but that is how it translates into. If you have a small shunt and you do not have a pH, the defect size has to be smaller. So shunt size you are calculating by echo. In today's world, clinical science don't have any value. You immediately jump to echo, and you are trying to size, and you are not able to see a VSD or VSD somewhere. where you cannot see it or find it, you are only seeing the evidence of shunt. Then a small shunt without any evidence of pH, it is a small size defect. If a small shunt with indications or indicators of pH, then it has to be a large defect. And large shunt is there, the defect size can be moderate or large. So again, same thing, small size defects don't cause hemodynamic problems. You need not bother, and in certain situations, you need to close them. Large defect may either cause heart failure and the patient may die or go in Eisenmenger. When do we call them? What is the size which can cause them? ASDs of 20, definitely more than 20 millimeters, they will be associated with Eisenmenger. In fact, Eisenmengers, if you see, they'll be having an ASD of more than 20 millimeters, VSDs of at least 7 to 10 millimeters, and PDAs of at least 5 millimeters. So by size also, you can sometimes say that it is not there. And if you are seeing the gradients, then if you are seeing a pulmonary artery pressure, which is less than 0.3 of the aortic pressure by echo, or whatever way you find out, this has to be a small defect, provided there is no pH. And if there is no pH, you are seeing the gradient here, it is pulmonary artery pressure is 0.3. It has to be a small defect and shunt. If pulmonary artery pressure is more than 0.7 of the aorta, it is a large shunt. So these are certain guidelines which examiners, when you will call it a large shunt, when you will call it a small shunt, depending upon the PA pressure. We are talking about the systolic PA pressure. In Polwood series, all the patients who had pre-tricuspid shunt had an atrial septal defect of about 30 millimeter. Half of this 15 millimeter was for VSD, and half of this 7 millimeter was for PDA. So these are the sizes historically in Polwood series. Now, presentations in post-tricuspid, the symptoms we have discussed is 3 to 4 weeks. There are three things: feeding difficulty, repeated respiratory tract infections, and failure to thrive. They are all related to left ventricular dysfunction with normal LVEF. They are all related to that. But these children, they are growing. Why? Because the epiphysis is getting the normal saturated blood. So the height will be there, but they will be thin because of catabolic state, because of heart failure. Compared to this, in cyanotic heart diseases, children will be small. So they are small for age, and these are thin for age or small. In pre-tricuspid shunts, symptom onset is delayed 9 to 12 months, and then dyspnea is not the symptom. Why? Because the LV has developed. Effort intolerance is there, and matured lungs are there, so they are more compliant. And you will have a larger shunt, 4:5, 4:1, 5:1 in these patients, and you will not have that in VSD or PDA. So they are able to accommodate more shunts. Now, what are the signs? I'll be combining the signs together, and we are going quickly, about 5 more minutes. So in pre-tricuspid shunt, there will be 3 features of left to right, large left to right shunt. One is cardiomegaly, second is flow murmur, and third is shunt murmur. RV type or LV type. Flow murmur can be tricuspid with RVS3, and mitral murmur with LVS3. Remember, if there is no flow murmur, S3 is natural in children. So only presence of S3 will not diagnose it as a large shunt. You have to have a flow murmur. And then shunt murmur in ASD, there will be no shunt murmur. However, there will be systolic or continuous shunt murmurs in VSD or PDA. But ejection systolic murmur at the base is considered as a flow murmur traditionally. In small left to right shunt, there will be no cardiomegaly, there will be no flow murmur, only shunt murmurs will be there. So that is how you will differentiate between small and large. Your idea is to get the large shunt out so that you want to focus them more. And these are the chamber enlargements. If you are a good clinician, you can see it clinically, or certainly by ECG, X-ray, and echo. So this is the sum. In atrial septal defect, these are the chambers: left atrium, right ventricle, pulmonary artery, aorta, and peripheral lungs. This is pre-tricuspid shunt. Left atrium will be smaller, right atrium will be larger. There will be no LV. RV will be abnormally large because of volume overloaded. Pulmonary arteries will be much more dilated because they have acquired hypertrophy after shedding that. And then peripheral lung fields in large left to right shunts will be perfused. Aorta will not be prominent. In VSD, left atrium and left ventricle are larger. Right ventricle is not that dominant. Why? Why so? You will not find right ventricular marked hyperkinetic as you see in the atrial septal defect. The reason is that the right ventricle has involuted in ASD, and then it has acquired That is a different kind of muscle. What has happened? Right in VSD and PDA, in VSD and PDA, remember intrauterine right ventricle was taking a load. From the very beginning, in utero, it has not shed its muscle. It was never hyperkinetic from the birth as well. So it will not acquire a hyperkinetic or forceful impulse. In VSD Eisenmenger or PDA Eisenmenger, parasternal impulse is generally not more than grade 1 or 2. And then peripheral lungs are again suffused. That is what will tell you whether there is an increased flow or not. Peripheral 1/3 of lung perfused, large shunt. Not perfused, small shunt. And what will happen with Eisenmenger? You can see here, the ventricular chambers, cardiomegaly will be gone. Chamber size will be reduced. The lung periphery will be clearer. Broadly speaking, the chamber sizes will be reduced. The lung periphery will be reduced. That is the two things that will happen. And definitely shunt murmur, flow murmurs, they will be reduced. So it will be more silent heart, smaller heart. You think that patient is getting better, but in fact he is in problem. How do you follow up large shunts? Echocardiography is gold standard, but sometimes you can follow them clinically as well. Clinically, you are looking for cardiomegaly, shunt murmur, and second heart sound. Second heart sound becomes important. For example, if you are following a large left-right shunt VSD, baseline, imagine if it's a large left-right shunt, not much PH, it's a wide split, loud P2. Because the capacitance is good, so split will be wide. In follow-up, what happens? The split becomes narrower, or it is normal with normal P2. Shunt has got smaller. If it is a narrow split, but loud P2, split P2, and then decide, then PH. Or if it is a wide split still there, but normal second heart sound, or soft second heart sound, probably he is developing a Gussul phenomena, or let's say developing the rare beauty obstruction. So that is how you can follow in there also. Why should we treat? Why? Because heart failure is there. Left ventricular dysfunction in later life can also happen, and you have to prevent the pulmonary arterial hypertension and arrhythmia and sudden cardiac deaths also. That is why you treat. Atrial septal defects, we will not go into incidences. There are various types, you know. ECG sometimes, all will present same with cardiomegaly, right ventricular volume overload, and ECG sometimes may help you. How? Because seeing the axis and loop of the ventricle, looping of the ventricle, you can decide what kind is there. Spontaneous closure of atrial septal defect is known till 1 year, maximum to 2 years. And less than 8 or 9 millimeters will close. But if it is at birth, or let's say at later stage, 3 or 4 months, if it is more than 1 centimeter, this is not going to close. So occasionally you hear a report of 4 millimeter ASD, don't bother about it. And this is the data. 87% of 3 to 5 millimeters ASD will close. But none of them with more than 10 millimeters will persist. What is the indication for treatment? Usually they are adults. You don't operate them earlier. Usually they are adults. And you say RA and RV volume overload generally by echo. You generally don't require a shunt calculation also. But still, paradoxical embolism may be there. So if you are having the evidence of right ventricular volume overload, then electively operate them by 3 to 4 years of age. Earlier, if unremitting CHF or associated PH or failure to thrive, I asked the pediatric cardiologists who are working day in and day out yesterday, 2 or 3 of them who are very, very famous in India, and asked them, who have more volume, I asked them, how often have you asked any child to be operated because of failure to thrive? They didn't have a data. He said, 1 in my life. The other said that probably none. So this is written in books, but it is already, it doesn't happen actually. And it doesn't happen because of the physiology. In late detected cases, you have to see probably the pulmonary vascular resistance to see whether it is operable range or not. Early closure is not required. You are not losing anything. But this is the data of long-term survival dependent upon the age. If you see here, this is the age till 24 years of age, or even up to 24 years of age, there is no difference between surgical, between the intervention and no intervention. But see here, beyond 21 years, 25 years, the age, appears to be a difference. So if you have to intervene, you intervene earlier than 25. And this is the, how is it related? Basically, what I want to say here is that pulmonary arterial pressure is another indicator. If the pulmonary arterial pressure is more than 40 millimeters, probably he will fare poorly. Operate him earlier than if it is a normal pulmonary arterial pressure, definitely before the age of 20 years. Modality of treatment, closure by pericardial patch using sternotomies, and then septal occluders are also there. Transcatheter closure can be done, but it is essential to see that rims are there, and the Indian guideline says that weight has to be more than 15 kgs, and it should be more than 4 years. The reason is that the atrium itself is very small. If you are closing it with the atrial septal occluder, then the devices, the rim which are there, which are beyond the diameter, may be eroding. So one should be very cautious about doing it in small children. These are the ASDs which are not suitable or primum defect and superior vena cava defects. And this is an important, interesting article. What it is trying to show is that if you do it in patients who are less than 45 years of age, whether it is device closure and surgical closure are having the same result, but if the age is more than 40, then the event-free survival with surgical closure is worse. So if you are intervening in a more than 40 years old individual, you should go for device rather than surgery. Ventricular septal defect is commonest. These are the types. Congestive heart failure is in large VSD, we know about it. This is the outcome. A spontaneous closure is there in 75% of small VSD, but large will not close. And another one which will not close is malaligned or outflow VSDs. AR may happen in 7%, Gasul phenomena or RVOT obstruction may happen another 10%. Spontaneous diminution, we have just discussed, small defects 75 to 80% will close down, and almost majority of the closures will occur before the age of 2 years, but they may close till 10 years also. Management, if it is a large VSD, usually it is managed when you encounter the patient, it is managed by drugs, and if you have to operate, you monitor them for weight gain, which should be somewhere around 150 grams per week. That is how you define a failure to thrive. 150 grams per week, it was not, then he is probably not thriving well. And then closure has to be done by 5 to 6 months. In small VSDs, don't close and follow them up yearly. Why? Because the event-free survival in small VSDs, 10 years is more than 95%. Small VSDs sometimes will need closure, probably when there is aortic valve prolapse, or when there is a AR. The most common prolapsing valve is non-coronary cusp. So if you are finding a AR, then operate. Or any VSD which has an infective endocarditis, close it down. Therapy of heart failure, digoxin has no role as believed, but it has no role. The only important thing is loop diuretics with MRA or ACE inhibitors. And transcatheter closure should also be done or may be done, but is not applicable to large VSDs, classical for muscular VSDs. Why? Because there are risks associated of complete heart block, and again, in very small ones, it should not be done. PDAs, incidence if higher is preterm is there. The natural history is nearly same as VSD. Aneurysm formation and calcification is there. In fact, this is the only lesion wherein the current guidelines say that in PDA in adults, because of risk of calcification, one should always close it by the device. Indication of intervention is that when there is a heart failure, you can intervene at 6 months. And then tiny echocardiographically detected PDA which has no murmur can be left, otherwise all PDAs have to be closed. If it is a significant in preterm babies, then look by the echo whether LV is enlarged or not, and what they say is that aorta is larger than LA, or PDA size is more than 1.4 per kg body weight, then close it down. You give indomethacin and then close it down. Now we come to, these are the closure devices which can be done. Treatment of choice, but weight should be not less than 6 or 7 kgs. So do we need to catheterize? Coming to these, some controversial points. Do we need to catheterize VSD and PDAs always? First is a scenario which is operable. There are certain clear-cut indications or non-invasive evidence of a large left-right shunt like failure to thrive, increased precordial activity, cardiomegaly, increased pulmonary blood flow, Q in lateral leads, good LV forces, LA-LV enlargement, you don't require them, operate, you don't catheterize. Why? Because the guidelines say that a patient who is having more than 2 years necessarily must be catheterized. No. And then if there is a clear evidence of shunt reversal with cyanosis, oxygen saturation at rest or exercise going to less than 92%, heart size has become smaller, peripheral pruning is there, then it doesn't need any operation. So in these two scenarios, you may or may not operate, and remember these two. Unnecessary catheterization is not to be done when there is manifest cyanosis. Borderline clinical patients create confusions. And then what to do? Then you have to catheterize. If PVR is less than 6 Wood units, you operate. In fact, your international guidelines, ESC guidelines says 5 units. But here, Indian guidelines say it is 6 units. They say that if it is less than 3 units, you operate. In 3 to 5, you see wait. But here, let us say that still 6 units you operate. If it is 8 unit, you don't operate. And in between 6 to 8, give pH modifying drugs and wait. That is important. From 6 to 8, you give pH modifying drugs, bosentan or PDE5 inhibitors, whichever you want to give, and then wait, reassess, and then operate. I would skip this. What about the borderliners? These are the borderliners. Children presenting beyond 2 years of age with pH. Operability is in doubt. These are different difficult subsets. If you operate, then is a problem. If you don't operate, then there is a problem. But if you are in doubt whether I should operate, there is a question coming to mind because the pulmonary arterial pressure is higher. What should I do? Please don't operate. Leave him. Why? Because his survival, if he develops Eisenmenger, is better. Rather than if he goes into heart failure and you close the defect, then it is a mess for the child. He will not survive if the defect is open. So I think I will stop here. I thank you very